All right, this last case is actually a patient that I saw at Freighter when I was doing some work there before I ever took over this course. It was a young guy. He was a 28-year-old male, and he had pulmonary complications during an open reduction internal fixation of a right tib-fib fracture. And in the note, it specifically said that his pulmonary issues during the surgery were due to restrictive lung dysfunction. He was actually transferred to the ICU after an ORIF, and that's where I saw him. He was 5'8" and he weighed 340 pounds. His BMI was 51.7. His past medical history was hypertension and hyperinsulinemia, and he wasn't on any medications. So you will see nowhere in here where you can point a finger at why they were saying that he had a restrictive lung dysfunction in terms of a pulmonary disease, right? Hypertension and hyperinsulinemia did not give somebody a lung disease. So why was this patient having such serious restrictions on their ability to get oxygen in that he ended up in the ICU after a broken leg? Let's take a look at his pulmonary function tests. So again, we can see percent of predicted in the final column. His vital capacity, 68% of predicted. So he has a reduced vital capacity. His tidal volume was even a little low. When you compared the tidal volume to vital capacity, that was within normal limits. So he wasn't taking up more of his vital capacity with his tidal volume. That again, this ratio helps to show you how much reserve they have above tidal volume. His cough flow rates were slightly low, and his ratio of FEV1 to FVC was 78%. So the ratio of the forced expiratory volume in 1 second and the forced vital capacity was normal, likely because both of these were lower than normal. So let's look at restrictive lung dysfunction caused simply by obesity. When you looked at this patient's chart, there was no disease that had affected the lung tissue, but he had a very high BMI and a high body weight. And when this patient was put into the supine position in the operating room, and the full weight of his fat mass was laying against his chest, they could not keep his blood gases stabilized during surgery. They couldn't get enough air in when he was in this position to oxygenate his body. And that's how he got into stress and ventilator pump kind of failure during his surgery, and what ended up putting him in the ICU. So he has a restrictive lung dysfunction secondary to obesity. And that first thing on your notes talks about a chest wall restriction. So the weight of the fat mass on the outside of the chest wall makes it very difficult to expand the chest. The excessive soft tissue is resistance against chest expansion. If you can't move the rib cage out effectively, you're not going to be as good at getting gas into all of your individual alveoli. So with chest wall restriction comes alveolar hypoventilation. Alveolar hypoventilation means you're not going to be appropriately exchanging gases at the individual alveoli. You can also get early closure of small airways and alveoli, especially at the base or dependent regions of the lung, because there's added weight on top of it. So with insufficient air getting to all the alveoli, to small airway collapse, this will impair our oxygen exchange and decrease our ability to get sufficient amounts of oxygen into the arterial blood supply. So the physical restriction of the soft tissue on the chest wall. The second reason there's a restrictive lung dysfunction is because of the weight of the abdominal contents, specifically over the abdomen, which is where a lot of the central fat mass is, forces the diaphragm into a higher position. It forces the diaphragm up, right? Because there's more pushing on it from down below. So it pushes the diaphragm up into a higher resting position, which can actually, because of the positioning, can kind of be one of the additional reasons for that atelectasis at the base of the lungs, because we're actually pushing into the base of the lungs here. But with the diaphragm pushed up, and you have resistance against descent. So if in order to use our primary muscle of inhalation, our diaphragm, the dome has to descend. In the supine position, we have an incredible amount of weight that is resisting, if his diaphragm is in here and it needs to go down, this is a lot of resistance to that muscular action. So the diaphragm is using so much force just to try to overcome the resistance of the weight of the abdominal fat mass that you do not get as much actual movement of the rib cage, which contributes to the impairment in ventilation. So other cardiopulmonary issues that we commonly see associated with obesity include sleep apnea. This is largely obstructive sleep apnea, that the relaxation of the muscle and the throat, the muscles of the throat and mouth, when the person sleeps, they collapse under the weight of the soft tissue. So most individuals who suffer from obesity are unable to sleep laying flat in bed. That's why a lot of individuals assume a nighttime habit of sleeping in a recliner to try to keep some of that soft tissue weight off of their throat musculature to prevent sleep apnea. It's very common to see a weak, ineffective cough. This is largely related to a mechanical inefficiency at your ability to generate enough expiratory muscle force to push the cough out. You can see right ventricular insufficiency. So if somebody is having alveolar hypoventilation, they're getting less fresh oxygen into all the alveoli in their lungs. You can get reactive pulmonary vasoconstriction, because the pulmonary blood vessels are going to try to redirect blood to the alveoli that have oxygen. So if you increase the resistance in the pulmonary circulation, the right side of the heart is going to have to work harder to pump into those lungs. And then it is highly associated with aerobic deconditioning. This will have an impact on their cardiopulmonary health because they're going to reduce the efficiency of oxygen transport overall. So they're going to have a less ability to use oxygen efficiently, and that will create a greater strain on the cardiopulmonary system. So my main goal with this final case was just to make sure this is on your radar, to keep into an account just the mechanical properties of increased weight on the chest wall and what that translates to in terms of physiological changes on this organ system. So I don't have some magic bullet of a technique you're going to learn in lab to overcome this. This is a restrictive lung disease based on the weight of the soft tissue mass. So really the only treatment is weight loss. If they can lose the weight, they can decrease the work of breathing, they can increase vital capacity, and they can increase ventilatory drive. But there isn't a magic bullet. There isn't a, you can talk to patients about the difficulty laying supine, talk about positioning, but after that, it's really about the mass on a rib cage, and the soft tissue mass just has to go. There are many, many other causes of similar restrictive lung dysfunction where something outside of the lung impairs your ability to stretch and open up. So you guys will see, some serious kyphoscoliosis or other forms of scoliosis where you decrease the mobility of the bony thorax. If the bony thorax can't move with the lungs underneath it, you're going to increase the work of breathing. So someone with a skeletal condition that looks like this, you would expect shallow, rapid breathing. In addition, this example particularly, you can see the great asymmetries between the two sides. This is going to interfere with normal lung mechanics. It can create altered pressure gradients and uneven lung movements that can contribute to lung water balance, impaired lymphatic drainage, which can increase the likelihood of fluid in the lung. There can be a lot of secondary complications when the pressures on either side of the system become out of sync with each other. Pectus excavatum compresses the mediastinal structures. The heart can actually get displaced and rotated, which can impede mechanical function within the chest wall. A whole host of connective tissues disorders can affect the ability to stretch the chest wall. So rheumatoid arthritis has components of that systemic disease that can affect the lungs directly. But secondary to that, pain and stiffness of the chest wall can limit the functional capacity of the lungs. In lupus, the skin and the joints of the thorax can be affected, which can lead to restriction, right? In addition to the possibility of inflammation of the serous membrane. Scleroderma is hardening and tightening of skin and connective tissues, creating like a cage around your chest wall and limiting the ability of that patient to get air into their lung. Polymyositis is an inflammatory myopathy. It has inflammation of many muscles, but proximal muscle weakness and loss is kind of a hallmark of that disease. It can play a huge role on pulmonary health. So if you have patients that fall into any of these categories, and there's many, many more that would ultimately, secondary effects of those conditions could impair pulmonary function, you want to be very aware that you're monitoring these patients safely. Any obese patient, you need to be monitoring their vitals in all clinical settings, not just inpatient, because these systems are affected by the elements outside of the lungs. And then we are coming in and we are straining the system by what we're asking patients to do, and we have to know what's going on the inside. Using dyspnea scales, watching for signs of respiratory distress, observing changes in breathing patterns. If they start using like a big upper chest breathing pattern, as soon as upper traps are kicking in during a normal inhalation breath, that is a sign of someone who's in distress, that they're using that muscle as an accessory muscle. That's kind of a big red flag. Put a pulse ox on their finger and make sure they're saturating their oxygen appropriately. Watching for cyanosis, abnormal changes in heart rate and blood pressure can all be signs they're not tolerating therapy well. I don't know if my notes printed out differently than yours, but my note page here looks like the notes are done. So make sure you flip to the next page, because there is one more page of notes that goes with this lecture. Mine might have just printed funny, but I want to make sure you don't start frantically writing things down when they're on the next page. When you see a patient with secondary pulmonary conditions where lungs are being affected by an outside of the lung problem, we can do things for patient. And a really big thing is just teaching them about that, about how a condition that's affecting their skin and their connective tissues is playing a role in their lungs. And just knowledge of that alone can make a huge impact, because they can recognize that limitation and monitor what they're doing and making sure they're behaving appropriately and safely, and using aerobic exercise and strengthening, making the periphery better at using oxygen. Weight loss and the secondary benefits that come from that with the aerobic exercise and strengthening. Postural correction and chest wall mobility. Just because you have a condition that decreases chest wall mobility doesn't mean it doesn't respond to stretching. So flexibility, opening up awareness of the association between different postures and their ability to breathe, and using posture when they need to get some good big breaths and they stand up really nice and straight and get those shoulders back. Range of motion, airway clearance, teaching activity, pacing, and energy conservation can all play huge roles here. You can set long-term goals for these patients based on their pulmonary deficits. So long-term goals might be to optimize lung volume, capacities, and flow rates. Optimize ventilation and perfusion matching, optimize gas exchange, maximize aerobic capacity and efficiency for oxygen transport, optimize their physical endurance and exercise capacity, optimize their strength and peripheral oxygen extraction will all have huge gains overall as their system becomes better at taking in and using oxygen, being able to manipulate flow rates to keep their lungs clear and healthy. So this final lecture piece is meant to keep in mind that the lungs hidden underneath some of these other conditions could be the limiting factor to their progress in therapy. I encourage you to add a cardiopulmonary assessment piece into a typical assessment for other conditions. Be bold, be brave, make a cardiopulmonary goal in a patient with a neurological condition, with a patient with a chronic connective tissue disorder. You will see the carryover into your functional goals when they are getting better at taking in and using oxygen and keeping their lungs clear and safe. All right, one little mini lecture at the end, and we got ourselves a wrap, folks. Thanks for all your attention. I look forward to seeing you soon.